everyone assumes that constipation is always a slow colon. That is not true. And in Sarah, there was nothing wrong with the speed of her colon. Her issue was right at the exit. The muscles, they're not relaxing, they're actually clenching.
When you are constipated, be honest, what do you do?
I mean, I would say, Chuck, having taken care of thousands of patients with constipation, I've seen that most people are ended up doing the same thing in the same order. More fiber, more water. And when that doesn't work, they step it up, they start doing laxatives. But if the laxative doesn't work, Chuck, what next?
Well, see, I have the solution right here. It involves a cup and more laxatives. And you see, you just unscrew the top, and then you take the laxatives and you pour it into the cup. And you take more, Dr. B.
Yeah, well, there you go, Chuck. But unfortunately for a lot of people, that strategy doesn't work for them. And so, you ramp up your laxatives, not getting results. Let me tell you what's happening there. In theory, here's an analogy. You're trying to empty a bathtub, and the reality is there's only one way to empty that bathtub, the drain. And what if the drain is closed? Honestly, it doesn't matter what you do with the water. You could drop all the liquid plumber in the world into that water, but the drain, it's still closed.
All right, so let's just see if we can get this analogy straight here. So the fiber, the laxatives, that's like liquid plumber. That's the Drano.
Yeah, and for about a third of people with stubborn constipation, they don't need the laxative. They need the drain to be fixed. The drain is the problem, and nothing that you add to the water is going to open that drain.
All right, Dr. B, here's the deal. I do believe that there are 4 patterns of constipation that you've come up. So today, we are going to be talking about how to know which pattern is your pattern and where to begin when you're constipated. And Dr. B, I also know that everything that we're covering today is featured in your brand new course called the Constipation Protocol, and that's open for enrollment right now. Matter of fact, not very much time left for people to sign up, so get in on that. Before we get diving into constipation, how are you feeling about the course, man?
Oh my gosh, I'm so pumped. Chuck, I have worked so hard on this course, and I cannot wait to share it with people. I think it's going to be a complete game changer for anyone who's dealing with constipation. So if that's you, now's your moment. Let's have you be a part of this with me. Let's make it happen.
All right, let's make it happen. Let's get things moving and moving right here on the show. So, Dr. B, I need you to put your game face on because it's time for rapid fire. You ready to handle the heat?
So ready.
All right, so that is a game face. All right, question number 1. If you poop every single day, can you still be constipated?
Definitely.
True or false? More fiber always helps constipation.
False.
Wow. Number 3, is there a kind of constipation that laxatives basically can't fix?
Yes.
And can diarrhea actually be a form of constipation?
It could, yeah, definitely.
And finally, what's the fastest way to get a genuinely slow-moving gut moving normally again?
Okay, this is going to surprise some people, but I'm going to say a stimulant laxative.
A stimulant laxative.
Yeah.
So how can there be so many different solutions to what I'm kind of assuming now is maybe one problem, but very much fragmented into its own problem for the individual, or at least 4 different patterns of it?
I mean, constipation is nuanced, it's complex, and I would argue that it's not one thing, and we have treated it. Like, I think if you say to the entire world, what is constipation? People are going to rattle off mostly the same answers, and what they're not going to understand is that there's different types of constipation. There's different patterns of constipation, and we need to direct the treatment. So, let me give you a quick example of a patient that I took care of in the past, who I'm gonna call Sarah for the purpose of this conversation.
Okay.
And by the time she sat down across from me, she had tried everything, and she'd been doing this for years, like more than 10 years, Chuck. More fiber, more water, of course, that's entry level. But then she started getting to the laxatives. Laxative after laxative after laxative, escalating, higher doses, new ones, prescription-based, the brand new ones that are super expensive. And she's cycling through every single thing, right? And she's constantly chasing, and she's never getting to where she actually wants to be, which is actual relief and comfort. So, Chuck, have you ever met anyone like this? Like, does this ring a bell at all?
Well, yeah, man. I mean, having gone through what I've been through over the last 3.5 years, I'm sure that my story differs from Sarah's, but I mean, there were long gaps in between trips to the bathroom to have an old sit down and think session in there. And that didn't matter what kind of laxative I was taking, how much I was taking, what I was eating, how much water. Like, it was a complicated case. And that literally, when I went to the Mayo Clinic, was the first thing that they tried to address. They told me time and time and time again, we really can't do anything until we get your constipation under control. And it always baffled me why they put such an emphasis on that, regardless of what specialist I was seeing.
Yeah, because your gut, so the reality, Chuck, is that your gut thrives on rhythm. And so when your gut is out of rhythm, it's hard for your gut to function and do its job the way that it's supposed to. And it zaps your quality of life. It leaves you bloated. If you can have discomfort, sometimes sharp, intense discomfort. Sometimes people think they actually need surgery. That's how bad it is. It can give you nausea, queasiness, make you feel full very quickly, and it drains your energy. Like, it's a shocking level of low energy that you have as a result of constipation. So everything that you're describing, Chuck, that makes complete and total sense. And here's the thing. Everyone assumes that constipation is always a slow colon. That is not true. And in Sarah, there was nothing wrong with the speed of her colon. It was nothing wrong with the transit. The plumbing, it was fine. Her issue, going back to the bathtub analogy, was the drain. Her issue was right at the exit. The muscles that are supposed to relax and open up when she is sitting down to have a good, healthy release, they're not relaxing, they're not releasing, they're actually clenching. And we call this outlet dysfunction. And it's a common pattern, most often seen in women, and it's the pattern where laxatives were never going to fix it. You cannot laxative your way out of a coordination problem.
So when you're saying outlet dysfunction, is that the same thing as pelvic floor dysfunction? Are they synonymous, or are these two different things?
Yes, so outlet and pelvic floor are basically speaking to the same thing. So outlet basically saying that, hey, look, the problem is down at the bottom, right? In that location, it's not clearing a path for you to release your poop when your body is ready to. So instead, it's basically like withholding and keeping it inside. And then when you keep it inside, your colon will draw water out of it. And next thing you know, you got a hard poop that's impossibly difficult to pass.
That's so wild. And it's like how it can swing for certain patients. I don't know if this was the case with Sarah, how she might swing from long bouts of constipation followed by diarrhea, then right back to constipation. In Sarah's case, did she have like her movements fluctuate like that?
So for Sarah, that wasn't exactly the issue. So there are many people, Chuck, who believe that what you just described is either both constipation and diarrhea, right? Right. That's what you just described. And then, or they see that as diarrhea with a break in between, right? Like the way that they interpret that is, okay, I like emptied my whole colon because I had tons of diarrhea, and then there was nothing for me to poop for a couple days. And so that's why I didn't poop, but then the diarrhea came back again. Okay. No, this is constipation. This is classic constipation. So basically what's happening there, Chuck, is this is, by the way, one of the ways that constipation can present with diarrhea. You back up, back up, back up, explode. When I say explode, on that particular day, there's a pattern to the day. You wake up in the morning, you finally have to poop. You haven't pooped in 3 days. You sit down on the toilet. The first one is possibly hard. The second one is closer to normal. But then you have to go back again. The urge is still there. And now it's getting loose. And next thing you know, you're in the bathroom 4, 5, 6 times, and it's explosive, urgent, watery diarrhea.
Not a lot of fun to go through, that is for sure. And sometimes, Dr. B, I'm going to be honest with you, sometimes it all comes out in one fell poop like a fire hose, man. It's Pretty interesting. But I want to get back to Sarah because it sounds to me like in Sarah's case, and what they wound up working with me on at the Mayo Clinic, which was helpful to agree, was that pelvic floor training, and so like it sounds to me in Sarah's case, she was suffering for a long time, but really didn't even need to.
Yeah, and the reason was because she wasn't getting anywhere because she was solving the wrong problem the entire time. So everything that she was doing was classic constipation treatment, but for a pattern different than the one that she had. So unfortunately, it was wasted effort, if anything, possibly making things worse for her and misdirected. So what we come back to is that we need to understand what we're treating in order to properly treat it. And when we pretend that constipation is just one thing, it's not, then you end up on generic treatments that are always the same. That's not what you should do.
Drop some numbers on me here, man. So when we're talking about constipation being a problem, like how big of a problem are we talking about?
I am convinced that we have a constipation epidemic. Now, that's not the hard data. I'm going to give you the hard data. This is what I've seen, and this is what I believe is happening. Like, I sincerely believe that 40 to 50% of America has at least some form of a constipation problem. All right. Now, in terms of the hard data, using Rome criteria, which, by the way, Chuck, was developed by our mutual friend, Dr. Douglas Drossman.
Shout out Dr. Douglas Drossman.
Dougie D. So that criteria is actually rather strict because in order to meet that criteria, you have to have a chronic problem. And so statistically, 10 to 15% of America meets the criteria. That's 1 in 6 people who meet the criteria for chronic constipation according to Rome. However, again, there are people that they haven't quite met that bar in terms of the intensity or severity of their symptoms, but they still have a problem. It's still affecting their quality of life. Their gut is not in a rhythm. They're not pooping the way that they should. And if we could get them into a better rhythm and get them pooping more regularly with better complete evacuations, they would feel the difference. And that to me is the threshold that I use is what is the opportunity to make people feel better? So, and by the way, real quick, Chuck.
Yeah.
Constipation is disproportionately seen in women. So we actually see at least double the cases in women. So that what that means is that, I said 10 to 15%, but for women, it's more like 20% or more of women are dealing with this issue.
So, I mean, really, then that's not rare no matter which estimate you run with. We're talking about, I mean, members of your family, your mom, your aunt, your cousins, your coworkers, your friends, everybody's kind of well, I don't want to paint the picture. Everybody's at risk, but I mean, no butt is spared. I don't know how else to kind of put it in this case. So way more common than we were thinking. But then like, why also then, if this is such a common problem, does it feel like no treatment works for so many of these people? Why is it nothing's working?
Okay, so let's get back to this concept of constipation is not one thing. There are 4 patterns. And you have to match the treatment to your pattern, right? So if you were to instead sort of like fan it out and instead of just calling it generic constipation and instead describe it as constipation with this pattern, then you start to get clear on what you need to do. That's the key.
Individualized constipation treatment a little bit. So let's talk about your 4 patterns here that you got. What's the first one that we should be looking for?
To be clear, as we dive into this, Chuck, and I want the listeners at home to be sitting here, possibly even with a notepad and a pen, and I want you thinking to yourself, is this me? Because I'm going to describe these patterns, and the key first step is to know who are you. And you might have more than one. That's definitely possible. All right. So that's not like they're not mutually exclusive. You can have more than one. Number 1, first pattern is normal transit constipation. Okay. This will surprise people. When I say normal transit, we're talking about the speed. We're talking about the way that your body works. I would describe casually normal transit constipation as basically being that the parts are fine, but your rhythm is off. And it turns out that this is actually the most common form of constipation, right? So when I said 10 to 15%, but I think there could be 40 or 50%, what we're really talking about is that delta. That extra percentage, up to potentially 40 or 50%, all those people, they're the ones who have normal transit constipation, because this is the mild form. It doesn't necessarily meet criteria for the Rome Foundation for chronic constipation. Your tests may come back normal. But yet, when you poop more vigorously, more regularly, you feel better.
That's the interesting thing, and maybe I even find some relief in that. I've experienced that in my own journey where, like, normal doesn't necessarily mean that nothing's wrong. You know what I mean? Like, which is kind of a gray area to be in, but nonetheless, it's not quite as dismal as you might think. Pattern number 2, what do you got?
All right. Well, quick comment on that. To me, normal, Chuck.
Yeah.
Normal means thriving. That's what I would classify as normal.
Well, that's the thing. Like, I can't tell you, like, how like frustrating and relieving it was to keep getting back normal test after normal test after normal test, and like have to keep digging, which is great because usually off the top, like, you're ruling out the worst stuff, and then it gets like really like you're diving into the nitty gritty. And yeah, it's just nice to know that normal doesn't mean that that's where things stop. There are still other things to try.
No, again, like, maybe you don't fit nicely into a bucket of a diagnosis. Maybe you don't fit so nicely into that. And so then the default becomes to say it's normal. But to me, anytime something is affecting your quality of life and making you feel unwell, you're not normal. Because if you were normal, you would be thriving. You would feel great. So we got to get you back to that. That's normal. Right, Chuck?
Amen to that. Amen to that. Pattern number 2, what you got?
All right. Pattern number 2 is where we get into sort of what classic constipation is to most of the listeners at home right now. They've been sitting here thinking, I would imagine most of you, and I'm not trying to put words into your mouth, but most people think of it as slow transit. It means the colon is sluggish. It's not moving the way that it should be. The slow lane. Right? So what's going on is that we have these pacemaker cells called and Chuck, I kind of love this, so forgive me for applying a bit of an accent to it.
What you got?
The interstitial cells of Cajal.
The what now?
The interstitial cells of Cajal.
If you say so, sir.
Yes. So, and I had a little extra English on that for everyone who's listening on Spotify and Apple Podcasts.
English? That was okay. I didn't know what that was, to be honest with you.
Chuck, I understand it was confusing, Chuck. There was something going on with my mouth that was meant for emphasis, and that was the English. Okay.
Okay, got it.
All right.
Okay.
We'll move on. We'll move on before I embarrass myself further. Nonetheless, that was a YouTube thing. Okay,
understood. I'm good.
Yes.
Yeah. Okay.
Yeah.
Anyway,
Yeah.
as you were, sir.
Anything can go viral these days, Chuck. You never know. All right. So the point being that these pacemaker cells, their activity is actually sincerely reduced. So this is the person who it's not going to be as easy as just add more fiber, add more water. It's not going to be that easy. We're going to have to do more to support this colon, and we're going to probably have to do more to get things moving in the first place, because that could be a challenge. So that's slow transit constipation.
I love that in the notes for this episode, just to peel back the curtain a little bit, it says fiber and water alone tend to bounce off the colon. I mean, God almighty, that just seems like, for somebody who's constipated, a cruel sentence. The fiber and the water that you're consuming to help, literally just bouncing off. It's not doing anything there. That's just brutal, man.
I mean, you lean into the fiber expecting it to help you, and we can talk about this as we move further along, because I do want to get through the 4 patterns. But
oh, for sure.
I mean, you do it expecting it to help you, but as I said in the rapid fire, it can actually work against you. So anyway.
Let's go with pattern number 3, man. Let's go with pattern number 3.
All right.
Water and fiber bouncing off, where do we go?
Pattern number 3 is SARA, which is outlet dysfunction, which is that the drain isn't opening. So, and it may be that the pelvic floor is clenching instead of releasing. It may be that particularly in women, you can have something called a rectocele, where the ligaments that actually support the vagina are more flexible than they should be. And the result is that the rectum, which usually sits right up against the back wall of the vagina, the rectum actually sort of bows out, and you can actually sort of have the stool move into that pocket as opposed to moving out the bottom. So that's another example of outlet dysfunction. And then the other thing, Chuck, is you could have issues down at the pelvic floor. You could have hemorrhoids. You could have an anal fissure. And those things can screw up the thing that we're trying to achieve, which is a nice, relaxed release.
Well, how would a hemorrhoid or a fissure slow up the release? Obviously, it's not going to be pleasurable, but how would it actually prevent you from opening up and dropping the kids off at the pool?
Okay, let's start with the hemorrhoids, and we're going to dig into this a bit anatomically real quick.
Yeah.
So hemorrhoids, we all have them. Even Brad Pitt, even Victoria's Secret models, basically really attractive people, they got hemorrhoids too.
Clip
right?
that, please. Please
Yes.
clip
that. And you, by the way, I've totally dated myself as Gen X when I'm the model of good-looking men is Brad Pitt, who's
Brad
65.
Yeah. Well done.
Okay.
But I didn't bat an eyelash. What does that mean for me or anybody else watching or listening?
You're right there
now?
with me.
Yeah.
You're right there with me, buddy.
Yeah.
So I'm quite sure there's younger people that the Gen Zers have in mind, but nonetheless, here we are. And so, hey, good-looking people, they got hemorrhoids too. That's my point.
That's right.
So
That's right.
And you can have internal ones or external ones. The external ones are the ones that hurt. The internal ones, they typically don't hurt, but what they can do is they show up in other ways. They can bleed. They can prolapse, where they're actually dropping down and getting into the bottom. Right? They can cause itching, an itchy bottom. Or you may have where basically these hemorrhoids, they have prolapsed down to the point where they're actually causing a partial blockage of the outlet. They're sitting in the way. They're physically present, sitting in the way. So then the solution to that, Chuck, is treatment. And what people need to know, this is, by the way, all this is stuff that we're covering in great detail in the constipation protocol. What people need to know is that the treatments for hemorrhoids, when I was early career, they made me cringe, even as a doctor. I was like, ooh, I don't want to do that. Ooh, I don't want to put a patient through that. Ooh, it's not good. And now I actually feel quite differently, because actually the treatments have made it quite simple and gentle for the vast majority of people to get relief from these hemorrhoids. So
going in there and cauterizing, is that what the deal is?
Ooh, no, that's quite scary. What they do is they have a device that's smaller than my index finger. I mean, granted, I have big hands, but smaller than my index finger. And it goes in 1.5 knuckles at the most 2. And you point it. There's 3 hemorrhoids, Chuck. I don't know if you realize this. We might have to do an entire episode on hemorrhoids.
I think we do at this point.
Yeah. There's 3 hemorrhoids. They're always in the same positions. And what you do is you point them towards the hemorrhoid. And what you do is you gently suck up the hemorrhoid tissue and slide a rubber band over the top of it. Now, believe it or not, that doesn't hurt because you don't have nerves in that area. So you slide the rubber band over the top, and then that hemorrhoidal tissue, it will just fall off. And now what you've created is a scar, and that scar actually helps to hold things up. So it's almost like suspenders.
Huh.
For what used to be prolapsing tissue. Instead of prolapsing down, now you've got the suspenders holding it up.
That's actually quite genius.
Yeah.
Well done.
Yeah, no, it's there is a device called the O'Regan system, and not sponsored, just saying. And it works incredibly well.
All right. One pattern to go, so let's move forward, and we'll circle back to hemorrhoids another time. Pattern number 4, what you got?
Okay, pattern number 4 is going to layer on top of the other patterns. So you already should have at least one of normal transit, slow transit, or outlet dysfunction. Pattern number 4, you layer on top. It's IBS. IBS-C to be specific, which basically, put into words, is constipation with pain. So this basically is where we have activated the sensitivity of the brain-gut connection. And those nerves, 500 million of them, carpeting, lining the intestines, they can develop something called visceral hypersensitivity, where they react and they respond to anything that sort of triggers them. And what's the trigger? The trigger is constipation. So you feel pain.
I didn't realize just how sensitive the whole digestive tract could be until recently. It is unbelievable. When you talk about a hypersensitive gut, I swear I was on the cusp of finding out how hypersensitive it could be. So just like everything I could feel, like from the second I swallowed until the second I got rid of it, it felt like it was just like, I forget how many nerve endings you said like line the gut, but man, every last one of those things were firing on all cylinders. It was incredible. But let's move on, man, because we talked about a lot of different patterns here. And we know what's actually going on in a lot of these cases, but you're making it sound also that because of these different patterns, certainly it's not a one size fits all thing when it comes to treatment. So is there something we can actually do with each one of these different patterns?
Definitely. And that's the key. That's actually the key, because you don't just want to diagnose to understand your own health issue. You want to start to personalize, and the personalization starts with knowing where you fit with these patterns. Okay. So if you know your pattern, you can develop your path moving forward. And then the choices that you make are going to be matched to that pattern so that you get exactly what your body is looking for. That makes sense?
It does. So let's go one by one with these patterns so we can kind of give people some tips. If they've got that normal transit kind of pattern, what would you suggest?
Okay, so again, this is the gentle one, and it's just a case of rhythm, right? So if what's missing is rhythm, then let's restore rhythm, because that's enough. You don't need to go aggressively after this type of normal transit constipation. So what you need to do is you need to build routines. Build a morning routine. Build a routine around hydration. Build a routine around honoring the urge when you feel it. And your body says it's time for you to go. You should honor that. You should go and do that. Building a routine around fiber and fiber supplements. And when necessary, a gentle amount of a laxative, typically an osmotic laxative. And once you do this, once you build that routine, you will build rhythm within your gut, and it will follow your lead.
All right. What about if the, transit time is just kind of in the far right lane and just creeping along? You got the slow transit. What do you do then?
The Sunday driver who's 92 years
dude.
old.
5 to 10 miles an hour below the speed limit. The
speed limit is 70 and they're going 45.
Yes, sir. You know it.
Yeah. Okay. Well, what we need here is ultimately to strive towards jump starting the bowels and then keeping them going. So I would use an analogy, Chuck, for slow transit constipation. Think of a freight train, right? Think of a heavy freight train. In order to get it moving, you have to apply a lot of force because it's so heavy. But once you have it moving down the tracks, it doesn't take that much just to keep it moving. So there's sort of two phases to taking that freight train and mobilizing it. The first phase is to get things moving. And in the world of constipation, I call that doing a jumpstart, where depending on how backed up you are, you have to match force with force to get things rolling. But then once you're rolling, you move into phase 2, which is, hold up, the train's not stuck. It's not stopped anymore. The train is moving. We're clearly moving. We're looking outside and it looks different. Okay, cool. Let's keep it rolling. And then let's focus on establishing the rhythm that we just talked about with normal transit.
What about somebody that might want to add something to there, like getting that back in rhythm? How effective would something like magnesium be in this case?
Magnesium, to me, so first of all, you need to know what form of magnesium you're looking for. Magnesium oxide, magnesium citrate, magnesium sulfate. I love magnesium for what it does. I think it does a certain job very well, which is that it draws water into the colon and it holds it there. and doesn't release it and let it go. And when we want good, healthy poops, we do, like, one of the strategies that we discuss in the constipation protocol is to soften our stool, right? And magnesium is one of the ways you can do that. By the way, that polyethylene glycol that you showed earlier, that's another way. That's another way. So it's a choice on what direction you want to go. Okay, but the other thing I will say, though, is that with both of those, all that you're addressing is the softness of the stool. It can definitely work for people. But Chuck, I would also argue I released a constipation video on August 18th. It just came out. And in that video, what I discussed is that there's 3 core elements that contribute to constipation that in a perfect world, we're going to address all 3. And one of them is the softness of your stool. So you got one, right? But you're missing the other 2. The next is motility. We want to get the gut into a rhythm and get it moving. Magnesium, polyethylene glycol, they don't do that. They just soften. And then the third is the microbiome. We want to take that microbiome and make it healthy. That's the long game. That's what ultimately we'll want to do. So that's actually why 38 Terra, I created, I'm the formulator, I created RCE, which is regularity and constipation ease, which addresses all 3 of those things. That's all I'll say on that.
Good to know that RCE is available for those who need it, but I want to shift gears also toward the people who have that outlet dysfunction. We were talking about the pelvic therapy here. So what can some of these poor souls do to improve their situations?
This is where RCE is not a good choice. You would not do RCE for outlet dysfunction, or at a minimum, you would do something else first, which is pelvic floor physical therapy. So the key here, Chuck, is acknowledging that 1 in 3 people with chronic constipation, this is their problem. That's a lot of people. They need to get the proper diagnosis, which they can work with their doctor to do. And then if this is the issue, many times the treatment approach is pelvic floor physical therapy. It's incredibly effective. It's effective like literally for 80% of people. And if you go and you start piling up on fiber and laxatives, you're just going to feel worse. You're not going to feel better.
And look, from experience, I can tell you pelvic floor therapy, like even as a guy, like it was kind of no big deal. It's like you show up for a few sessions, you run the tests and you walk out of your life, like, or walk on and continue on with your life. Like, and you do like at least the sessions that I had, they were really effective at like teaching you how to essentially retrain your muscles down there to get them working efficiently again. It was really a fascinating process, to be honest with you. I never put much thought into training your muscles down there, but sure the heck enough, you can, just like going to the gym.
Chuck, the tables have turned. I'm now interviewing you. Is it just Kegels for 2 hours, or is there other stuff?
Kind of, sort of, but like a lot of it was just like literally learning how to control those muscles. It's like everybody thinks about how to flex your biceps, you know, and all those types of muscles. But how often do you actually like sit and think about, oh, well, let me see if I can, you know, flex my pelvic floor? Like, who does that?
I think, not to be divergent, but it's actually a conversation on some level of neuroplasticity, which is our brain is constantly learning and adapting. And it's kind of shocking how sometimes you have to reteach the brain. So many times athletes after injury, they have to reteach their brain to do physically the same things that they used to do so effortlessly prior to the injury, right? And the same is true in this setting and let me bring this up real quick, because I touched on this very lightly, but I want to continue to try to help the listeners as much as possible. When you feel the urge, you should honor the urge. And the reason why I bring that up is the downside of not honoring the urge, which is that you're now teaching your body not to pay attention to that urge.
Man, so you can't be doing those long car rides all the time. I would wonder then, like, if bus drivers, truck drivers, people who are on the road and literally basically trapped in their seat for long periods of time, if they may have higher rates of pelvic floor dysfunction in that.
Yeah, we do. We see that now. Pelvic floor dysfunction is far more common in women, but it does happen in men too. And we will see it in people that have that type of situation where they don't really have the ability to stop when necessary. We also sometimes see this in people who they have a long commute in the morning. And because of that long commute, they've basically taught their body that, hey, you can't poop between 8 and 9 in the morning. And well, that's that's tricky because depending on what time you wake up, that's when your body may be wanting to poop. So, or some people, it's very common. Some people, they just don't feel comfortable pooping away from their home, right? It's not just like the airport. It's like even at work, they just don't feel comfortable.
Oh, I remember.
And so they try to sort of, avoid that restroom because they don't really feel comfortable with it. And then the problem is that the next thing you know, you got a constipation problem.
Understood. I think there was a big scene in that movie American Pie about people who wouldn't poop in public restrooms. Anyway, random note. Moving on.
Which of the 6 American Pie movies are we referring to?
This
Chuck?
would be the original, my friend. It would be the original. High school boys having shenanigans. All right, here we go. There is one pattern left that we have not yet discussed before we move back to cinema. IBS-C. This is perhaps the most interesting one to me. What do you got here for us?
Okay, well, so again, this is like in layman's terms, constipation with pain. So what I would say is I've just given you how to approach 3 different types of constipation, and I've already told you you have at least one of those 3.
Yeah.
So you got to do that. You got to address the constipation because the constipation is the trigger, right? So if you take away the trigger, then the stimulus to create pain is gone. You will feel better if you address the constipation. But at the same time, we should be working on addressing the brain-gut connection. And we want to dial that down and turn down the visceral hypersensitivity so that our body is not so responsive to all these stimuli. And there's a number of ways that you can do that. In the course, we discuss pharmacology options, but we also discuss like totally free things that you can do. Here's a quick one. Breathwork. Breathwork is actually quite incredible, Chuck. The pattern is 4 seconds in through the nose and 6 seconds out through the mouth. Now, I know that you know this. We call it diaphragmatic breathing. And in a moment, I want you to comment on this, but I'm going to give you the study first, and then you comment. They did a study where they took a group of constipated people with IBS, and they had them doing this, 4 seconds in, 6 seconds out, and this was basically activating the parasympathetic nervous system, activating the vagus nerve, getting you into rest and digest mode, getting you into a state of relaxation, which is what you actually need to have a good evacuation. And what they found is during the course of a month of doing, and again, they were doing quite a bit of this breath work. It was not like they were doing 1 minute a day, but by doing this on a daily consistent basis, this alone, no other intervention led to increased stool frequency, increased comfort. So they were addressing both the constipation and the IBS.
From experience again here, I just feel like today's show has just been like talking to me. I can tell you that the breathwork component is massive. I think that whether it was on the Gut Insiders or on the Exam Room, you and I have talked about my experience with that. And this was, again, something that, the top gastroenterologist whom I was working with at the Mayo Clinic pointed me toward. And I hate to keep name dropping Mayo, Mayo, Mayo. It's not about that. I'm just saying this was the program I went through. And of all of the complicated, phenomenal, like 21st century medicine that they practice, this simple free tip that anybody can do was by far and away the most helpful when I was in distress. And there was not even a close second. And Dr. B, if I'm lying, I'm dying here. To this day, I use breath work when anxiety hits, when my symptoms flare up. And within 10 to 15 minutes, I'm not saying I feel perfect, but I've definitely reset the system and then can continue moving forward and getting things back in rhythm. Love breath work.
Yeah, so rhythm is the key. Rhythm is the key. Now, don't get me wrong. Sometimes you need rescue medicine. And sometimes medicine is part of what contributes to maintaining that rhythm. So I don't live in a world where we say medicine is totally off limits and we can never go there. No. What I want is a world where we are pulling the levers that make a difference. That includes in your daily habits, in your patterns, in your breath work, in what you eat, in how you relieve your stress, in terms of your movement and the things that you do there. Chuck, there are so many things that can be done. People don't even realize that ultimately come back to helping your gut get into a rhythm, maintain that rhythm, and help you to keep things moving through efficiently and good complete evacuations. So, and that is basically what the constipation protocol is really about. We do discuss medication. We do discuss supplements. We do talk about strategies to bring all of this together. But what I really want people to know is what you just said, which is that this simple free tool, all you got to do is do it. But it really starts with knowing that it exists. You have to know it exists and that it works first.
Yeah.
And that's really what all this is about, both this conversation today and also the constipation protocol.
Well, I'm here to say it's real and it's spectacular. So, I think that it's great. And I think that it's phenomenal that this is in your course. Like, I think that it should be in every GI course. And as you get into it, you'll find that there are like more, different ways that you can do it. You can do 4-6, you can do 4-8, you can find what works for you. So in the constipation protocol, are you going to be going over that, the various different ways that people may be able to try this themselves, get the benefit?
Well, here's the good news. You'll see, I can simplify that quite quickly for everyone who's at home and curious about that, because I'm sure people are wondering that. So you'll see different patterns. Sometimes it includes like breathing in and holding it and then releasing it. So what everyone needs to know is when it comes to activation of the parasympathetic nervous system, activation of the vagus nerve, which is what we're striving towards here, it's the slow release that is the key.
Yeah.
And whether that's 6 seconds or 8 seconds, or for a certain person who the best they can do is 4 seconds, but for them that's slow, doesn't really matter. Because it's the slow release that's the key. Now, like doing a breath hold is a totally different thing and does not activate your vagus nerve. Holding your breath, like breathing in, holding it, and then releasing it, what you're doing there is you're getting your body accommodated to carbon dioxide. And so it does, there's some sort of advantages to your body being adapted and adjusted to, sort of carbon dioxide levels rising ever so slightly, and you're just used to that. But that doesn't affect the constipation. What you need to know for constipation or for relaxation is it's the slow release that's the key.
Has belly breathing or diaphragmatic breathing been tested against the other, various forms here? I mean, people with outlet dysfunction, the slow transit, or even the normal transit, is it effective there or just the IBS-C crowd?
Okay, so slow transit, normal transit, this is 100% in play. There is no downside to any of them. If you have outlet dysfunction, I wouldn't tell you that you're wrong to initiate a breathwork protocol. But what I would tell you is you still need to adhere to the lesson, which is that in the context of slow transit, pelvic floor therapy tends to be the starting point because you need to address that first.
All right.
Right.
And we're going to circle back to what we addressed first here today on the show with the rapid fire questions. Now that we've answered a lot of them, we're going to come back to them. But I just want to circle back one more time to the constipation protocol here, because, I mean, literally, Dr. B, you're talking about a deep dive that lasts 2 weeks. Includes, I know that you busted your hump putting this together, like tons of knowledge, 30 videos, a 60-page workbook, all going to help people master constipation. Because as you said at the top, I mean, this is a huge problem that we're facing here.
Yeah, 100%. And, the bottom line, I just want to add real quick to the breathwork thing, is one of the other things that I do teach in the course is that there's bathroom breathing, which is not the same as diaphragmatic breathing. So diaphragmatic is what you do when you're in a relaxed place separate from the bathroom. But in the bathroom, there's a certain position that we want to get in. There's certain ways that we breathe, and those can be helpful to the person with outlet dysfunction. So anyway, bottom line, constipation protocol is actively getting started right now. Now's the moment for people to jump in. You really should not delay at all. And the cart closes, like basically the last chance to jump in is on Sunday, August 30th. So link is below. Go find that, and you will be able to work through all these things, figuring out what your pattern is and knowing exactly what to do and literally building your constipation protocol. It's not just the title. It's literally what you're going to build by the end of the course.
I love the fact that bathroom breathing is in there because, yeah, I've forgotten about that. They actually taught me how to lean on the toilet and everything, getting just the right position. I mean, they had this down to a science, which it very much is. It's awesome. I love the fact that you're getting into all of that, man. So go and sign up. All right. You ready to tackle the rapid fire one more time, sir?
Let's get after it.
All right. Question number 1. If you go every single day, can you still be constipated?
So the answer is clearly yes, right? Because constipation is not just how frequently you go. There's other factors, including like, is this a good complete evacuation? Are you emptying? Are you moving things through the way that you should? So bottom line, the answer is you could go every single day. You could still be constipated.
True or false? More fiber always helps constipation.
So in normal transit, it tends to really be helpful. In slow transit and outlet dysfunction, the problem is that if you don't actually get things moving, if it stays stuck, if the freight train is sitting on the tracks, then that fiber just starts to pile up and accumulate, and it's going to give you more gas and make you feel worse.
Question number 3. Is there a kind of constipation that laxatives, sir, just cannot fix?
Yes, and it affects 1 in 3 people with constipation, and that is outlet dysfunction.
Can diarrhea actually be a form of constipation?
Yes, you asked me about this, and we talked about it where it's like the pattern of back up, explode. And by the way, if you want to dig into that question even further, you should watch my video from August 18th.
And finally, what is the fastest way to get a genuinely slow-moving gut moving again?
This is going to surprise people, so I'm saying stimulant laxative. We didn't get a chance to really dig into this today during the conversation, Chuck, but it's a part of the conversation within the Constipation Protocol course. Stimulant laxatives, it's, there's people who say they're the worst thing ever and you should totally avoid them. There's other people who say, don't worry about it. There's nothing to fear there. Actually, the answer is far more nuanced, and that's part of what you're going to hear me talk about in conversation in the course.
Well, I didn't realize that they were like such a third rail issue for you gastroenterologist types, the stimulant laxatives. Did not realize.
Yeah. There's actually, even among gastroenterologists, there's a little bit of controversy on this topic. So, what we're talking about are like Senecot, Dulcolax, but also aloe or Cascara sagrada. So these are common things. A lot of people are taking, like a lot of the constipation supplements that you buy on Amazon. This is what they give you. And the question has always been, does it lead to a floppy, dead colon? Right? Does it lead to colon failure when you use it long term? And that's basically what I'm tackling in the course. And it's a complex question. So what I do is I let the data guide me to the answer. But what I will say here today, because it would take me longer to really dig into this, but what I will say here today is that when you got to get things moving, like if you're a little bit backed up and you want to be pooping by tomorrow, this is the way that you do that. The osmotics, like polyethylene glycol or magnesium, they don't work overnight. They need a little bit more time.
There you go. All right. Well, let's get your pooping on track. Remember, enrollment for the Constipation Protocol closes on Sunday, August 30th. That link is down below. So go ahead and find your sweet relief. And by the way, if today's episode helped you, if you found some sweet relief there, or you found someone, somebody, they're stuck in that same daggone loop, send them this episode. Let's get them some help too, because sometimes the right information landing at the right time can change everything. So if you're not already subscribed, go ahead and hit that button. We're doing this every week, and you don't want to miss what we got coming up next. So find us wherever it is that you listen to podcasts as well, whether that's Apple or Spotify. Watch us here on YouTube. All of it, that is where you can find the Gut Insiders, Dr. B.
Let's go. I'm so pumped. Thank you, everyone, for being here, and go and find your pattern and address that directly.
And we will see you next time.
Thanks, everyone.